Good evening, dear friends. In the recent history of medicine, perhaps no other disease has troubled us, stimulated us, and divided upon us COVID-19. With the barrage of information accruing on a day-to-day basis, it has become a challenge to separate the wheat from the chaff. Today's panel discussion is promised to make us a lot better and wiser in understanding and managing the nuances of COVID-19. With this brief introduction, may I now invite Dr. Sunny P. Orathil, a well-acclaimed professional who is currently holding the position of Medical Superintendent of Rajagiri, to take over and conduct the session. Thank you.
Thank you, Dr. Radhakrishnan.
Thank you, sir.
Dr. Ravi, IMA President, and Dr. Radhakrishnan, Chairman, APA Kochi. We are really honored to have this session of COVID-19 from APA Kochi chapter. Now, as you know, Cochin IMA in association with government authorities, doctors and doctors of private and government sector are discussing COVID-19 management and practices of COVID-19 on every Tuesday at 8 o'clock. Based on the inputs and inspiration received from that discussion, we thought of bringing practical issues in the management of COVID-19. For that discussion, today, as Dr. Ravi said, we have got 4 eminent panelists with me. And may I introduce all of them? Dr. Rajiv Jaydevan, he is the immediate past president of Cochin IMA. He is a senior consultant gastroenterologist of Sunrise Hospital, Kakanad, Cochin. And he is the member of National Task Force on Corona Epidemic. He is doing commendable research on all aspects of COVID-19. And he is regularly appearing in national, international, and local channels almost every day. And the second person who is having the on the panelist is Dr. Abraham Itachin. He is the professor and head of the Department of Internal Medicine, and he is a consultant in critical care also. He is managing critically ill patients, and he belongs to MOSC Medical College, Kolancheri. The third panelist for the discussion today is Dr. Rajesh Venkatakrishnan. He is the head of the Department of Pulmonary Medicine in Rajagiri Hospital. He is an interventional pulmonologist, and he is also a fellow in critical care. He is also managing COVID-19 cases in intensive care. The fourth in the panelist is Dr. Renoy Henry. He is the Associate Professor of Internal Medicine, Amrita Institute of Medical Sciences. As you know, Amrita probably may be having the large number of COVID-19 patients. So all the 4 panelists have rich experience in managing COVID-19 cases. So let us hear from the panelists. To roll the ball, may I ask the first question to Dr. Rajiv Jaydevan. Dr. Rajiv, it is said that the present surge in COVID-19 is due to a second wave. What do you mean by second wave? Is it due to a mutant COVID-19 variant? Dr. Rajiv. Dr. Rajiv, please.
Greetings to all. Thank you, Dr. Sunny, and thank you to all the organizers of the meeting. The answer to the question is, as you know, the profile of the virus has changed in 2021. The latest, absolute latest genomic analysis has shown that the old virus has almost vanished from Kerala. I have the information from Kerala with me, and that sent it to a few of my colleagues, including yourself. We know that 1.617, that is the so-called Indian variant, has taken over about, it is there. If you take 100 people in Kerala, 60% are having it right now, as we speak right now. Last month, it was much lower, and the month before that, it was completely absent. So we can now see the rapidity by which the profile of the virus is changing. And these are hard facts. So the answer to your question, therefore, is that although we are not facing a new pandemic, the character, behavior, and the profile of this pandemic is changing, mainly because it is spreading faster. The 617 variant is spreading faster, almost 2 times as faster by various models than the previous virus, or maybe even more. And therefore, the second wave is almost 6 times bigger than the first wave. If you calculate it based on number of cases by time taken. For example, speed is distance travel by time taken. If you calculate the size of a wave by the number of cases by time taken, it's at least 6 times as big as the first wave. Unfortunately, when we look at data around the world, for example, Japan, Japan is in the 4th wave now, each wave is much bigger than the previous. So there are factors beyond our understanding, but what we do know is this second wave has really, damaged India, and there will be further waves. There is no doubt about that, but I think we need to be really prepared in our strategy to counter that. I hope that answers the question.
Dr. Rajiv, are the new mutant really dangerous?
The 617 is the so-called double variant. That's a wrong term, but most people have heard the word. It is not dangerous. By itself, this virus has the same level of seriousness or severity or what's the word for that? It is what we call virulence as the first version, or the Wuhan version, or the slightly modified 614G, which is what was circulating around the world. So in other words, the 2021 version does not kill more people. Say if you take 100 people, you give 100 people the old virus and you give 100 people the new virus, the same number of people will die. Same number of people will get sick. Same number of people will go into ICU. But the difference here is when a virus spreads faster, 2 things happen. One, the total number of people who are infected is more. Remember, in India, whether you believe it or not, 77% of our homes are 2 rooms or less in size. I know it's very difficult to comprehend that. That's a fact from our census. 77% of homes in India are 2 rooms or less in size. You can imagine how rapidly this virus is spreading. And that statistic itself explains the scale of the tragedy. So back to our question here, this virus is rapidly spreading. The second thing that will happen is whenever hospital systems are overwhelmed, mortality goes up. Now, the latest studies on that has gone one step further. It shows that you don't have to have an overflowing hospital system for mortality to go up. Even when they are nearly full or getting full, mortality will start going up. Last year, we were thinking that only when hospitals are over full or we can't admit patients will mortality go up. The reason is clear, because quality of care depends on us, healthcare workers. If we are strained, if we are given more people than we can handle, it is simply not possible to keep the mortality rate down, and various other factors. So on both these counts, yes, definitely it's a dangerous virus, but by itself, it does not cause more damage than the old virus. The hospitalization rate, published hospitalization rate from B16172, which is the dominant sublineage, is 1.1%, which is exactly the same as the old version. And this data comes from Public Health England. Thank you.
Thank you, Dr. Raju. Dr. Noy, during the second wave, the number of cases have gone up. How can you categorize and triage the cases? What's the benefit of triaging COVID-19 cases?
Good evening, everyone. Yes. Good evening, everyone. Hope I'm audible. As Dr. Rajiv just said, I think overwhelming the hospital scenario and health structure and infrastructure is an important problem. So I think categorization and triage is one of the most important ways in which we can actually prevent it. Government of Kerala has already done this categorization. We have been following it up from the last year onwards, where we categorize patients into A, B, C. A being people with mild symptoms like sore throat, cough, mild fever, diarrhea, rhinitis, etc. And people with category B are the patients who have comorbid illnesses. Comorbid illnesses would include something like any organ dysfunction syndrome, patients on long steroids, immunosuppressants, or age more than 60. And category C comes in where there are any worsening of these underlying conditions, or is there any breathlessness and other associated features which fits into the severe category. Now, these categories are further stratified on the basis of the clinical severity or disease, based on mild, moderate, and severe. And I'm sure all of you all know about it. So what I would like to propose is another addition to this particular thing, where we should know about the phase of illness that the patient presents to me. That means we know that there is a viremic phase, there is an early pulmonary phase, a late pulmonary phase, and probably a hyperinflammatory phase that occur, which actually overlaps with the early and late pulmonary phase as well. So different treatment strategies, different investigations are required at different phases. And how can you know this particular categorization? By knowing the symptom onset, the day on which you had the first symptom. And that is an important history that we need to take to categorize the thing. And how do we triage? Yes, triage is just prioritizing who should get the urgent care. So basically it is to triage to make sure that the right patient gets the right treatment at the right location at the right time. Okay, but understand this, that triage is something like an ongoing process. So another addition is that these patients should be constantly re-stratified at the right intervals. Otherwise, we will miss the bus. If you stratify one patient as mild and do not triage them again, we are going to miss the bus again. I think Kerala has done a wonderful job. The New York Times have actually published this particular literature saying one state charts its own COVID course. And it's big salute to the wonderful leadership that is shown by IMA Kochi, as well as the young enterprising doctors who's managing the war room. It's a big salute to the entire team there. Now, if you look at how this can be implemented, I mean, district level it is there, state level it is there, we have to have it in an individual hospital scenario as well, where you triage patients sticking on to the guidelines. Some of the tech-savvy students in Amrita has done something like a algorithm-based analysis, where if a patient comes to category A or mild symptoms, they are forwarded to a particular team of home quarantine team. If the patient comes into category C or severe class, they're directly given to the admission team based on the algorithm. And this particular team basically looks at the feasibility and logistic behind getting this patient into the hospital. Now, if there's a bed that is not available, yes, then you have to actually discuss with the district and then find an ICU bed. If it is category B, sometimes an interim can be done, because all category B patients need not be admitted. So it is important that a teleconsult is done and then decided whether this patient should go into the home quarantine team or the admission team. And this is something that is actually going on. We started in Amrita, this is in the initial stages, which is helping. This is because every hospital has its own clientele. State is doing a wonderful job, the district administration is doing a wonderful job, but definitely the state, each hospital also needs to actually have its triage. Hope that answers your question.
Oh, thank you, Dr. Noy. Dr. Ityachen.
Yeah.
Because, just now, Dr. Noy mentioned about triaging and investigations for triaging the patients. So what are the relevant investigations and biomarkers you can rely in the management of COVID-19? And also, you have to mention about the importance of pulse oximetry and the pitfalls and the precautions that has to be observed in looking into the pulse oximetry.
May I first thank all the senior members of the IMA for giving me this opportunity to participate in this discussion. Regarding the first question, which Dr. Sunny just mentioned, I would say that before biomarkers are to be considered, you first see the patient. I'm basically a clinician, and I would always take it from the patient and then go on to the biomarkers. Though in literature, we speak about CRP, D-dimer, LDH, and ferritin. Ultimately, it's the patient that matters. And we have been treating, like most of my colleagues now, more than 1.5 years, sick patients, only the difference being that this year we have more severe patients. And though we do all the 4 investigations, which I told just now in the initial phase, for follow-up, we usually depend only on CRP. Now, CRP, ferritin, D-dimer, they are all acute phase reactants. But the one that is probably best in monitoring a patient would be CRP. Now, one important thing which I would like to mention here is partly which has already been mentioned by my friend Dr. Renoy. What we know very clearly is that the danger in a patient with COVID-19 is a cytokine storm. That is what we should watch out. And in people who have been admitted, who come early, and sometimes people who on their request whom we admit, we have very clearly seen that the first 1 to 7 days, sometimes they're asymptomatic, and 7 to 10 days, you see a fever spike, rigors, and you follow up the markers, you find out that there is a gradual rise in CRP, and corroborating that, you can see new infiltrates appearing on the lung, and also your pulse oximetry saturation going down. So CRP would be the one which I would recommend, because regarding ferritin, mind you, it is an acute phase reactant. It can go up in so many conditions. The same thing holds for D-dimer, because in coming to D-dimer and COVID, there are a lot of controversies that there's a lot of microthrombosis taking place, and D-dimer can persist for up to even 4 months. In fact, there was a review recently in a journal of hemostasis and thrombosis, where they showed that even 4 months after recovery, about 1/4 of the patients had a high level of D-dimer. So in the initial phase, it may be useful. After that, it may not be useful. CRP would be the one which I would bet on. Now, coming to the second part of your question, sir, regarding pulse oximetry. Pulse oximetry is something where you have to be very careful where you intervene. I mean, when you interpret the results. Now, we have good pulse oximeters, that is true, but there are some pitfalls. Now, one thing which I noted recently, we recently had our general election, and a lot of cases, in fact, my own nursing staff were putting this pulse oximeter on the hand where you had that indelible ink. And remember that any indelible ink or even the normal Q-tex which we put, which affects the function of the pulse oximeter. The pulse oximeter works on a principle of absorption of infrared and red rays by oxygenated and deoxygenated blood. It's actually a differential absorption. So one thing is that there should not be anything on your nails. Second thing, that there should not be any peripheral vasoconstriction. There should not be any hypotension. And ultimately, you should also look at whether the wave pattern is there. So taken all together, you should interpret. And one very, very important thing which I would probably recommend is that the pulse oximeter sometimes may give you a false sense of confidence. For that, may I just ask you to recollect what we learned long back in your physiology, the oxyhemoglobin dissociation curve. Now, if you can remember the oxyhemoglobin dissociation curve, if you look at the oxygen saturation, at around 90%, 90 to 100, there is actually the oxyhemoglobin dissociation curve is actually plateauing. Actually, hemoglobin is almost 90% saturated. The moment you drop from 90 to 85, you are actually going into the steep phase of the hemoglobin, the oxyhemoglobin dissociation curve, and your oxygen delivery rapidly comes down. So it is not the same like, say, 90 to 95 is not the same as 90 and 85. The drop is much more. So using pulse oximeter is a good thing, but you should know how to interpret it. And please remember that the difference between 90 and 95 is not the same as 90 and 85.
Okay, thank you, Dr. Itijan. Now, Dr. Rajesh,
Yes,
just now, Dr. Itijan mentioned about the use and pitfalls of pulse oximetry. But as a doctor, we have to address the symptoms first. What are the symptoms you want to address the patient at home? Do you want to prescribe any drugs, any antibiotic? And when will you ask the patient to consult the doctor whenever the patient has got varying symptoms? Dr. Rajesh.
Good evening, and thanks to all senior members of IMA Cochin and API Cochin for giving us this opportunity. And thanks to Sunny sir for including me in this panel. Sir, yes, absolutely true, sir. Rather than numbers, we always look at the patient in toto. Yes, pulse oximetry and the pulse oximeter values are important because that's one of the reasonable ways of remote monitoring. But the other symptoms that I would look at would be the persistence of fever or the reappearance of fever after the first week. Again, the degree of shortness of breath as perceived by the patient. How well does he tolerate feeds? Does he have any vomiting? Is he able to take adequate amount of feeds, and is the urine output adequate? Does he have significant loose stools? How tired is he? Is he able to walk by himself and carry out his day-to-day activities? These are probably some of the things that I would try to assess the patient when I am having a remote consultation. Now, anyone who is having a persistent high-grade fever or someone whose saturation values are continuously falling on a day-to-day basis, or someone who is not able to adequately take food because of vomiting anorexia or diarrhea, or someone who is too tired to even wake up from the bed, then depending upon the status of our hospital beds, I would really love to have him nursed in the hospital. Otherwise, if we have the luxury of a lot of beds, probably most of them would actually be on a hospital observation, but unfortunately, we don't have the luxury now.
Dr. Rajesh, do you want to prescribe any antibiotic as a routine thing?
Not really, sir. For two reasons. One, I feel that routine antibiotics for all COVID patients would be over treatment and something that is not really documented by evidence and literature. And secondly, if the patient has a second indication of antibiotics, there is a very clear-cut indication of a secondary bacterial infection. And what I would look at would be someone who has a structural lung disease previously, like a bronchiectasis or COPD, and then the volume and purulence of sputum really goes up. That would be the category of patients where I would love to prescribe an oral antibiotic. But beyond that, I won't love to routinely prescribe antibiotic on a patient who is on home quarantine.
Dr. Raju, do you want to comment on that usage of antibiotics? Dr. Itiachan, Dr. Noy, all of you can contribute. It need not be a one-handed answer.
Yes, Dr. Sunny, the topic of antibiotic stewardship is well known to all of us physicians and to all doctors in all specialties. But unfortunately, how often do we see good antibiotic stewardship in practice? Very rarely. That's unfortunate, because if you look at an average prescription for COVID-19 in the mildest COVID-19 patient all over India, you will see a list of around 13 medications. Literally, they throw everything into it's like a big buffet thali that you get in these restaurants. It is unfortunate because the same patient who's sitting in any developed country will get 0 medicines except paracetamol as needed. And it's the same disease, same virus, same science. But why are we being different in spite of all this knowledge? So these are questions that we must really ask ourselves. I do not believe that, exactly as Dr. Rajesh said, I do not believe that patients should receive antibiotics at all unless there is a compelling reason to suspect a bacterial infection. I'll give you an example. If you are doing a ward rounds in, let's say, in any of the hospitals in England, and you are a consultant and you ask your nurse to start an antibiotic, you may get a call from the antibiotic stewardship committee and saying, doctor, we noticed that you ordered a particular antibiotic. Can you explain the rationale? They won't fight with you, but they will ask you a question. Then you have to explain why you chose the antibiotic. You can't just say the patient had fever, so I started an antibiotic. They'll throw you out. You have to explain, look, this patient, just like Dr. Rajesh said, this patient is a patient with bronchiectasis and the sputum character has changed. There's a little bit of blood staining. The temperature has gone up. The patient looks sicker. There's a change in the patient's status. And compared to the time the patient was not on antibiotic, I have a strong suspicion of a bacterial infection, and therefore I'm choosing to upscale, and there's a chance of a nosocomial infection. Only if you make a rational statement like that will they even authorize the delivery of the prescription to your patient. But you switch to India, you have patients on outpatient patients who have had mild symptoms, who have just have fever and a sore throat, or just a fever and a runny nose. They come with carbapenems. I mean, I think this should be seriously taken up by responsible bodies like API and IMA, and I think unless we start now, we are in for the long term, and a lot of people are getting these prescriptions, and it's completely wrong. So I think this is a signal for action on our part. Thank you.
Thank you, Dr. Rajiv. Dr. Noy, just now you have mentioned about the importance of triaging and all. So how will you manage a category B patient in the hospital and the role of anti-inflammatory agents? So because this has been discussed a lot in many of the forums, the role of anti-inflammatory agents, particularly steroids. Dr. Noy.
Hello.
Dr. Noy. Dr. Noy. Okay, I will come to Dr. Noy after a little while. Dr. Rajesh, same as the case of steroids. all studies are coming with the role of anticoagulants. What's your advice on the role of anticoagulants in the management of COVID-19 cases? Dr. Rajesh.
Yes, sir. Yes, sir. So there are very few reasonably proved things that actually work in COVID-19. And perhaps one of them is prophylactic anticoagulation. Now, I'll put it this way. Someone who is not hospitalized, who is otherwise comfortable sitting at home, minimal symptoms, not hypoxic, if he doesn't have an additional indication for anticoagulation, then probably prophylactic anticoagulation is not worthwhile in someone who is comfortable at home. Whereas anyone who is admitted in the hospital, unless there are contraindications for anticoagulation, he becomes a candidate for prophylactic anticoagulation as long as we are ruling out an acute thromboembolic phenomena like a deep vein thrombosis or a pulmonary thromboembolism, because we know that COVID-19 is a procoagulant state. So in the absence of contraindications and in the absence of ongoing acute thromboembolic phenomena, everyone receives prophylactic anticoagulation. There has been thoughts of three different doses: the standard prophylactic versus the intensive or high dose prophylaxis versus the therapeutic. Now, most of the recommendations have more or less concluded that standard prophylaxis is adequate for almost all of these patients. Now, we have to remember that these patients have a lot of microthrombi and they can even have large vessel thrombi, as in the case of deep vein thrombosis, cerebral events, or pulmonary thromboembolism. Now, anyone having a acute thromboembolic phenomenon, then he goes into a therapeutic anticoagulation dose in the absence of contraindications. And if he is having a pulmonary thromboembolism with hemodynamic instability and all, then he goes for lysis. So I think the message is very clear that anyone who is hospitalized requires prophylactic anticoagulation. Someone who has an acute thromboembolic phenomena, he goes into a therapeutic anticoagulation. Whether we should treat an elevated D dimer alone during the course of hospital stay or at discharge is a matter of controversy, but then most of the international societies now tend to think that an isolated D dimer elevation alone doesn't mandate therapeutic anticoagulation or prophylactic anticoagulation at discharge if he doesn't have a second additional risk factor like recent surgery, recent trauma, immobility, obesity, etc. In the absence of that, just don't treat an elevated D dimer alone. I think I would. This is one aspect where I would really invite opinion from my co-panelists also.
Yeah,
may
Dr. Sunny, may I just interpret? I was actually waiting to add what Dr. Rajesh just added. See, regarding this anticoagulation, I think we should take it from two angles. One, a patient who is admitted in the hospital, and one, a patient who is discharged. A patient who is admitted in the hospital, so even if you go by the Government of Kerala classification, the clinical severity of staging classification, that is moderate or severe, several studies from around the world, not necessarily India, even postmortem studies have shown that if you look at the lungs, which is one of the primary organs where COVID takes a big hit, the pathogenesis of ARDS, it's not the usual pathogenesis what we thought it would be. Actually, a lot of it is due to microthrombi also. And so it is very clear, like Dr. Rajesh told, that such patients certainly need anticoagulation. Now, coming to patients who are being discharged, I was just reviewing this topic, both international society guidelines and from different states of India. I was quite surprised that, I'm not putting in a pejorative manner, but I was quite surprised that if you go into the guidelines or the West Bengal government guidelines, it's actually very beautifully given, better than the Kerala government guidelines. Anyone can access this on the Google. When the patient is discharged, and his D dimer is high, how they have divided the patient, this is something very easy for all of us to understand. A patient who has got additional risk factors for thrombosis, like he's a diabetic, dyslipidemia, past history of stroke, coronary artery disease, in addition to the normal anticoagulants like either clopidogrel or icosapent, they advise starting the patient either on apixaban or dabigatran, that is a antithrombin inhibitor, or dabigatran that is acting 10A inhibitor, apixaban. Actually, mainly they advise apixaban because it does not require dose adjustment in renal failure. For other patients less than 45 years, even for them, what they advise is that if the patient had a severe COVID, give ecosprin for actually at least 1 month. And when I went into one of the Scandinavian journals, they also were advising this. Actually, no one is very clear as far as international guidelines are concerned how long you should give anticoagulants, but most of them say a safe bet would be to give at least ecosprin. No, that's a cheap drug also, especially for patients who recovered from a moderate to severe COVID, at least for 1 month. Thank you, sir.
Thank you, Ketan, for the expert comment. Back to Ranoy's,
Yes.
yeah. Just like we were mentioning about anticoagulants, the role of anti-inflammatory agents is very much in use in COVID management, particularly steroids. So what's your comment on that, and which steroid you want to propose for the management of COVID-19?
Yes, thank you, sir. So steroids definitely has been one player which has actually stood the test of the time. I mean, from the initial recovery trial and towards all the other meta-analysis that has come in, this has got definite mortality benefit that is there, that is documented. So now, when would you start a patient on steroids? Obviously, the clear guidelines that mention in the state guidelines and all the other guidelines is whenever there is a patient who is desaturating, or the patient who is actually requiring oxygen support, then you will initiate the patient on steroids. But we also need to look at other indications. A patient who is having a recurrence of fever after about 7 days or so, or patient complains of significant fatigue and exhaustion, probably after 7 days or 8 days, definitely would also be a candidate to add steroids, especially in the early or the late pulmonary phase. Now, which steroid? Definitely, it's an important thing. Dexamethasone has had the maximum support from everywhere, and everybody definitely this cheaper one as well. So I think maximum usage is of dexamethasone, which is started as 6 milligram dose. But any equivalent dose ideally would not be a problem. I think we've had experiences earlier where for ARDS and other things like that, we are giving methylprednisolone, and a lot of pulmonologists and critical care physicians actually prefer methylprednisolone over any other steroids. But still, most of the guidelines and most of the studies are being on dexamethasone. I prefer dexamethasone to go on in an Indian scenario because it is actually much cheaper. So anything is possible. If you have a problem in availability, I think you can choose anything at a comparable dose. But definitely dexamethasone would be the one that is there. Now, a patient who's on steroids suddenly develops a clinical worsening. That means a CRP suddenly shoots up to more than 75. The oxygen requirement suddenly goes up. And you've given steroids at least for about 24 to 48 hours. The patient has an absolute lymphocyte count that is less than 1,000, elevated serum inflammatory markers, and who does not have a poor prognosis, where patient is unlikely to survive over 48 hours from the screening. And if there is any absence of systemic bacterial or fungal co-infection, I think these are the patients where you have to choose and give the IL-6 inhibitors like tocilizumab. But this has to be always in discussion with the institution, the nodal officer and other team, a central core team which actually manages these things, and then choose this. Because we've seen that like steroid, which is a double-edged sword, this also can cause significant problems. And with the experience of using it in Amrita, especially in the critical care scenarios, we've kind of come down on the use of toci because there's significant bacterial infection and sepsis that occurs after that. And we lose out patients because of the bacterial infections and sepsis that occur after that. So I think this is the most important thing. These are the two anti-inflammatory that is available to us at this particular point. There are other things that are there, like baricitinib, which can be used along with remdesivir. Baricitinib is a Janus kinase inhibitor, which has two actions: an antiviral action, which actually prevents the entry, as well as immunomodulatory action. And along with remdesivir, it can be used as an oral dose of 4 mg per day. Studies have shown a decrease in the overall hospital stay in such patients.
Yeah, thank you, Dr. Noy. Dr. Rajiv, during the first wave itself, consultants, particularly those who are working in the intensive care unit and critical care unit, were fond of administering plasma for management of COVID-19 cases. What's your call on plasma therapy? I know very well that you had a lot of research on that.
Yeah, in putting it very bluntly, plasma does not work. It's pointless. It's not just me, but many people who have actively been involved in this program have come out and said, including those from Mayo Clinic. The reason is that COVID-19 occurs after the virus gains entry into our cell. See, antibodies predominantly work before the virus gains entry into the cell. It's a very simple logic, actually. Now, after the virus gains entry into the cell, what matters really is adaptive immunity. And adaptive immunity, for the most part, includes T cells. I'm not saying antibodies are not important, but by the time the patient's been diagnosed and the patient has been admitted to hospital and the decision taken to administer plasma, that window, that extremely narrow window of opportunity has passed. Therefore, all of the plasma trials to date, including India's own, have been negative. And they have been consistently negative from the beginning. But there's a social angle to this. See, in India, it is very difficult to convince patients that you do not need something. They want something. See, patients want some action. They want something dramatic to be given. And I'm told that doctors come under social pressure to, quote unquote, do something. And if you administer plasma, it has a lot of, it seems very divine. You're giving a liquid, liquid has some divinity to it, socially speaking. So you're donating a clear liquid derived from a survivor, which has some sort of an energy. And so I think that's the way society sees it. I think we should really look at how society sees it. So even if the doctor explains it is not necessary, the patients may demand it. I think that drove plasma therapy for a long time in India. But as I said in the beginning, it doesn't work. It has to be given up completely.
Well, thank you, Dr. Rajiv. Dr. Dijan, in symptomatology and clinical presentation, a lot of similarity is seen between COVID-19 and many tropical diseases. Dr. Dijan has done pioneer work in leptospirosis and all from Kochi. So the monsoon is on, and so the tropical diseases. What's your advice regarding clinical presentation and differential diagnosis with regard to COVID-19 and other tropical diseases?
So speaking about COVID and leptospirosis, I think I need to go back a little bit into history. Way back in 2003, when I joined my present institution as an young assistant professor, I was seeing a lot of patients with leptospirosis die of ARDS. A person who had leptospirosis, when he developed ARDS, it was actually a death warrant. If he goes on the ventilator, you could tell the relations he's not going to survive. Now, since I had come fresh from a training in critical care, and I was aware of the ARDS network trials, but this was an article that came in NEGM long back. But the ARDS network trial, they had actually consistently shown that steroids were not useful in ARDS. But no tropical country, no tropical disease was treated with steroids, that is methylprednisolone. So we had one patient like that, whom we had almost given up. In fact, I told the patient that he's not going to survive. I mean, I told the relations. But since there was nothing left to do, I thought, why not start methylprednisolone? Because in many cases it has worked, not in leptospirosis. So with the permission of the senior faculty at that time, I used methylprednisolone for the first time in a case of ARDS due to leptospirosis. And you won't believe it, the patient who was not expected to survive, he went home walking. So I had to eat my own words. So in the subsequent few months during that lepto season, that is the monsoon season, I could actually fine-tune the use of methylprednisolone to around 40 milligrams 6 hourly. And I published it as a paper in the Indian Society of Critical Care Medicine. That's a journal of the Indian Society of Critical Care Medicine. And now it is quoted by 2 countries, that is the national guidelines of Philippines and Sri Lanka, as one of the first treatment for ARDS in leptospirosis, or although very surprisingly, our government, Kerala government, doesn't accept it. So last year, when the recovery trial came up and they were telling that steroids, now here it's dexamethasone that's useful in ARDS due to COVID, I was surprised for two reasons. The first reason being, I think all of us are aware from our MBBS days, we are all taught that never give steroids in a viral infection because it suppresses your immunity. It actually leads to secondary infections. But that was very surprising. Suddenly, one moment, everything turned upside down. What we learned, now we realize that it was wrong. Now we are giving steroids, and mind you, high-dose steroids to treat a viral infection. And the second thing is, what surprised me, but not, I would say not very surprised, the way the steroid was acting in a patient with COVID, that is the ARDS. And then I suddenly realized it was the same phenomenon I had observed many years back in leptospirosis patients. Now, coming to your question regarding the similarity between the two, even last year after the COVID pandemic came, we had cases of leptospirosis. Initially, mistakenly, some of them were mistaken for COVID in the clinical presentation, but the COVID antigen and RT-PCR was negative. Otherwise, the same clinical features, body pain, upper respiratory symptoms. The only thing that gave us a clue was there was a definite risk for leptospirosis. Most of them had contact with soil or water. And the same patients, we actually used, like we were using dexamethasone, and it worked instead of methylprednisolone. So there was a lot of similarity between two, not only in the treatment, but also in the symptomatology. And that I think is what we physicians who treat tropical diseases should be aware of. Now, in the coming rainy season, because the pandemic has not ended, we are going to see, especially people who practice in rural areas, we are going to see a lot of leptospirosis. And be careful, don't mistake one for the other. The important thing about leptospirosis is when you start antibiotics, you should start early. Otherwise, the morbidity and the mortality is high. But one good thing is that actually, at least steroids act in both. The ARDS part is taken care of. Over to you, sir.
Thank you, Dr. Hitesh. Dr. Naik, it has been observed that the patient with COVID-19 lands up in complications because of comorbidities. Which are the comorbidities you want to address or you want to take care in COVID-19 patients?
Yes, sir. So these comorbidities have already been listed, and I think the category B itself has actually come because of these comorbidities. I think we are aware of that particular factor from the beginning. And when I look at the literature, most of the literatures after about June 2020 have not actually really focused on these comorbidities. It's a different matter that we are only actually appreciating trends in the second wave and have really not looked at it in detail probably in India. But the major comorbidities that we have to look at, definitely one of the most important one being age, which is more than 60 to 65. Any organ dysfunction, whether it's a heart failure grade 3 or grade 4, uncontrolled obstructive airway disease, a CKD stage 3 and above, a decompensated liver disease, all of them become an important risk factor here. Also, patients who are on immunosuppressive drugs, patients who have a malignancy, whether it's a solid organ malignancy or a liquid malignancy, and is on chemotherapy for that, and other lifestyle diseases like an uncontrolled diabetes, hypertension, dyslipidemia, and one of the most important thing being obesity. I think according to the BMI, there have been studies which says that actually as the BMI progresses, definitely the risk is actually much higher. And this is something that we have actually seen in regular practice when we actually have seen patients, especially the young ones. Again, another important thing is pregnancy, especially this wave. We have seen much more mortality in pregnant women than in the other thing. Another important thing, especially now, since we have started vaccination, is we definitely have to ask a history of these patients, especially the patients with comorbidities, whether they have been vaccinated or not. Without vaccination, definitely, I feel that should be added as a comorbidity now. A patient who has not had a vaccination definitely puts themselves in a much, much higher risk than this. If you look at the current scenario and the current wave, few observations are that this does not follow this kind of a rule. We are seeing actually a lot of young people who are probably not having any of these diseases are still becoming symptomatic, requiring ICU, and some even actually not making it. So what is the missing link in this particular wave is something that we have to figure out. There are only trends now available, and we cannot completely ascertain this is one comorbidity is actually more worse than the other.
So I actually fully agree with Dr. Renoy's observation. So we have been also treating the same patients, and unlike last year, we are seeing lots of young patients who are getting sick, but no risk factor, the type of risk factor that is described in literature, and we don't have an explanation. And as Dr. Rajiv Jayadevan just mentioned, we don't know, is it because of this new mutant? No, we don't have an explanation here. We are also seeing a lot of young patients who are becoming sick. Absolutely no other risk factors.
Thank you, Dr. Noy. Thank you, Dr. Itchen. Dr. Rajesh, people are fond of using ivermectin, and previously people were using hydroxychloroquine. What's your comment on the usage of ivermectin and hydroxychloroquine? Dr. Rajesh, please.
Yes, sir. Just like Dr. Rajiv Jayadevan previously said, a blunt answer from my side would be that neither of them works, and probably I don't use either of them in my own practice, either for prophylaxis or for therapy. But then probably they are cheap drugs, so they found initial mentions in the Indian guidelines. Now also ivermectin finds its place in some of the guidelines. That's the probable reason that I can think of. I don't believe, and I don't think the literature and evidence is robust enough to recommend the regular use.
Yes, that's the answer. Okay, Dr. Rajiv Jayadevan. Nowadays, it is there is a practice to think of 2-deoxy-D-glucose. What's your comment on 2-deoxy-D-glucose?
Yeah, the thing about 2-deoxy-glucose is it looks like it was fast-tracked all the way to DCGI without any of us knowing about it. I honestly have no idea how it reached there. As far as its history, I'm sure all of us are aware of its history. It is a failed drug that was originally tried in cancer patients because of its property to block glycolysis. Now, I don't think there's any need to go into the biochemical mechanisms of blocking glycolysis because that will be esoteric here. But we don't have any published data. The difference that they claim is actually quite small in terms of percentages, and they have not given a confidence interval. And when you don't give a confidence interval, we lose confidence in the fact that we don't know if the differences are actually significant. And the lack of a confidence interval, or when a confidence interval crosses 1, we know that adequate numbers have not been studied, and the conclusion is erroneous. So there's a good chance that the conclusion is erroneous. And personally, I'd be very reserved. I'd have a lot of reservation in prescribing to any patient with COVID-19. I think we need to get people to understand that less can be more. But unfortunately, across India, there is a cultural mindset that more means better. More drugs, more treatments, more interventions means better outcomes. But I think we just have to continuously tell people that less is more. And unless a well-conducted, well-published paper that is peer-reviewed comes out, I would not even think of prescribing this agent. And I know that there are fake messages floating around. There's an audio message. It sounds like it was made by a very convincing actor who claims that there was a miraculous improvement on that. This is the kind of WhatsApp contradictions that we face in everyday practice. These messages float around in patients groups as well and doctors groups. So it is very difficult to counter that. But I think we just have to wait for a paper to come out. At least it must be peer reviewed, because a lot of papers come out under the guise of well-conducted trials, and many of them are fake in the sense fake research, which are manipulated. I think we could maybe in one of the future sessions, one of us or two of us can hold a session on how to spot a fake research. Thank you.
Okay.
I just want to add something to it. I mean, regarding 2DG, especially the WhatsApp message that came in, where that drastic reduction in the oxygen requirement is what was actually highlighted there. I mean, the basic pretext is that the hypoxia occurs in the early pulmonary or actually late pulmonary phase. The basic reason why which this postulated action of this drug should be that the virus does not replicate too much. The viral load comes down because such cells are actually affected by the by stopping the glycolytic pathway. So the basic thing is ideally it should more work in the viremic phase where hypoxia should not be there. But they chose to say that the oxygen requirement is drastically coming down, especially as less as 5 minutes. And I don't know whether 30% saturation can be even recorded in such a situation. So that definitely was a fake message, I feel, and definitely that's something that we should be aware of.
So may I add one thing to what Dr. Rajiv just told? No, he was just mentioning about a lot of society pressure. And just to give an example, a couple of days ago, I had a patient who had a post-mastectomy for CA breast on COVID, of course, on the ventilator, very high PEEP. We had done PROD, and she was not going to survive. So one day the husband came to me and said that, see, he has got an agent somewhere from north, from Gujarat. They will give this magic drug that is the one we just mentioned. So I told very politely, you know, we personally doctors, we think it doesn't work. But as a compassionate therapy, I don't mind giving it. So like Dr. Rajiv told us, sometimes there is a lot of pressure from our patients and society to do something. Whether it works or not, it's immaterial. But you have to do something. But this patient unfortunately passed away 2 days ago. But just to highlight the fact, sometimes we face a lot of pressure from the society and patients to do something.
Okay, Dr. Dijan. Dr. Dijan, what is cytokine storm? You mentioned earlier about the youngsters getting affected and dying of COVID-19. What could be the reason?
The cytokine storm is actually not something that is new. It has been described first in graft versus host reaction. That it was there, it first came into literature. And like I told you, in my personal experience was it was at least 15 years back when I started treating leptospirosis. There, it was seen that a patient who had sometimes treatment would have a Jarus-Herxheimer-like reaction, and suddenly a CRP, SR, everything went up. But mind you, at that time, we didn't have lab facility to check for interleukin levels and all. Now, coming closer to 2020, we find that the same thing occurs in COVID-19 also. And mind you, not in all patients. Let's not forget the fact that if you look at COVID literature, right from the literature that starts from China, of the 100 patients, 80 to 85%, mind you, have only mild illness or they are asymptomatic. Only 15 patients develop serious illness, and among them, only less than 5 develop critical illness. So that's actually something very good. Although, like one of my colleagues, our panelists just mentioned before, in a country like India with 1 billion people, even that 5%, it adds to a large number of patients, Now, coming back to the cytokine storm, what you just mentioned, a person who develops COVID, mind you, not all of them, like I just mentioned, less than probably 5%, by around 7 to 10 days, suddenly there is a rise of fever, his respiratory rate goes up, his saturation goes down. If you look at the micromolecular level, it's thought that the dendritic cells, the other cells which are infected by the COVID bacteria, the COVID virus, suddenly it releases macrophages, T lymphocytes, which in turn actually release the cytokine, which again attract inflammatory cells. And suddenly we have inflammatory cells attacking the different organs of the body, mainly your lungs. Now here, of course, the theory pathogenesis is all fine. As far as clinicians are concerned, the practical aspect which I have learned and which is given in literature is we have to intervene at the onset of the cytokine storm. And actually for that, our Kerala government guidelines comes in very handy. That is actually junction of category B and category C. That is from moderate to severe. That is a junction. We should not allow patients in category B to go to category C. And from my experience here over so many months, I've realized that patients who are admitted earlier, if we can take care of the cytokine storm, that is towards the end of category B, that is they're just trying to go into category C, actually we can prevent them going into category C and even prevent the patient from going into the ICU. And all you need to do is DEXA. That's my personal experience here. DEXA, rather high dose, I would say, at 8 milligram at least TID, the starting first day, and then depending on your clinical features and CRP, gradually taper it down. Only very rarely have I had the need to use tocilizumab. Most of them was treated with dexamethasone. But here, the important point is catch them at the correct time, at the onset of cytokine storm. Once cytokine storm has set in and you have organ damage, whatever drugs you give doesn't work. And one thing which I've noted here is that lot of patients are, I don't know whether they're self-treating or they've been given by doctors. At the moment they know that they're COVID, they are self-treating with steroids, and that is a very bad thing. It's a wrong drug at the wrong time. It is very well proven that if you give steroids in category A patients or even early case of category B, not only do you suppress the cytokine storm, you are actually increasing the viral load, but you're postponing the cytokine storm. The cytokine storm comes in much more forcefully. So here, that's the second point I'd like to lay emphasis on. When you give steroids or whatever to give, treat cytokine storm, please do it only at the onset. Never give it before. There is no prophylactic role for steroids.
Okay, Dr. Itejan. Dr. Rajesh, being a pulmonologist, you are always favoring inhaled steroids. A few minutes back, Dr. Noy and just now Dr. Itejan mentioned about the importance of steroids and the way how to give steroids. So what's your call on inhaled steroids, role of inhaled steroids in the management of COVID-19?
Okay, sir. I would put it in two ways, sir. Someone who has an otherwise indication for inhaled steroids, like someone who is asthma, who has a COPD, or even many of those people have a COVID-associated airway hyperresponsiveness. For them, an inhaled steroid, especially combined with a long-acting beta-2 agonist, an ICS-LABA combination would be worthwhile. The only caveat that I would like to make is, yes, nebulizations are not absolutely contraindicated, but as a strategy to minimize dissemination of infection to caregivers and the surroundings, I would probably request a metered dose inhaler with a attached spacer and a face mask. So that would probably decrease the duration of the chance of dissemination of infection. That's for someone who has an otherwise indication for inhaled steroids. Now, whether inhaled steroid per se is having any role in the therapy of COVID, I probably think no. There are a couple of studies which actually said that a combination of ICS-LABA, formoterol with budesonide, actually prevents progression of COVID and really prevents severe disease and all those things. Even prior to the COVID becoming a major health problem, there was a study in JAMA, if I am not mistaken, of ICS-LABA combination preventing to the progression of ARDS in those with a high ARDS risk score. But then all of them were pretty small studies with a lot of loopholes. Even in the peer review, it was found that there was a significant difference between the control group versus the study group. When you remember, the JAMA study had hardly 60 patients. So due to all those things, I would probably put it in summary that for COVID per se, inhaled steroids probably don't have much role. If the patient has another indication like asthma, COPD, or COVID-associated airway hyperresponsiveness, then probably go ahead and use steroids. And the best formulation, if the patient is reasonably stable, would be a metered dose inhaler with a spacer and an attached face mask.
All of us know that lung is the one organ that is always affected with COVID-19, and COVID pneumonia is the order of almost all ICU patients, and almost, or at least few patients are landing up with lung fibrosis and all. So what's your experience with managing antifibrotics to these patients?
I would say that any recommendation or evidence of antifibrotics in COVID is still at its infancy stage. Rationalistically, yes, COVID, especially severe COVID, is a disease which can significantly destroy the lung, and you expect some degree of post-COVID fibrosis. And given the large population of India and the large number of COVIDs, we are bound to see a substantial number of patients who are left with residual COVID fibrosis. But I have a few words of reservation regarding antifibrotic therapy in COVID. First of all, as compared to other fibrotic interstitial lung diseases like idiopathic pulmonary fibrosis or connective tissue related to interstitial lung diseases, post-COVID fibrosis is not a hugely progressive fibrosis. Yes, during the COVID phase or active COVID phase or immediate post-ARDS phase, you have an acute insult. But once the patient comes out of that, maybe after 1 month of the acute illness or something, then the fibrosis is probably not going to progress because it's not a self-perpetuating mechanism of fibrosis. One. Secondly, you start giving the antifibrotic usually it takes 1 to 2 months to exert its effect. So, and a fibrosis that is not ongoing and a drug that is not going to act immediately, so how do you really place it? The only way that I can speculate is that someone who has a very severe pneumonia, ARDS, who has a high risk of progression to fibrosis, probably initiate him at the peak of his disease itself in the hope that probably that will prevent fibrosis. But that's just a rationalistic thought. I think we need a much more bigger body, a substantial body of evidence before we start really recommending it. Having said that, we have two antifibrotic agents. One is the pirfenidone and one is the nintedanib. Both agents have been aggressively promoted by industry as well as some of our colleagues for preventing post-COVID fibrosis, but I haven't really started using it on a very large scale in my own practice.
Okay, Dr. Rajesh. Dr. Rajiv, since last fortnight, lot more discussions are happening around COVID-19 and black fungus. And yes, and you had some research on that, and more than 4 lakh people shared your views in internet handle. So can you comment on black fungus, and if possible, white fungus, yellow fungus, lot many fungus are there? Yes.
Yes, Dr. Sani, the thing about mucormycosis is, see, the first problem I saw was that people were dismissing it based on old textbook data. See, the textbooks were written, say, a few years ago based on chapters that were submitted over a period of a year. An average textbook takes chapters over a year. And each chapter is written by somebody who refers to journals that were published the year before at least. And those journals, articles would have been based on work that was done several years prior. So by the time a textbook comes out, it's at least, say, 5-10 years old. So the point here is COVID-19 is a new disease, and COVID-19, the combination of COVID-19, steroids, and diabetes is there in all countries. But this particular problem, mucormycosis, more than 8,000 cases is only occurring in India. I network with doctors all around the world. This is not there in other parts of the world, except in small numbers. So my point here is, if we depend on data that is 20 or 15 or 20 years old, we're going to miss some very big findings that are staring at us in the face. Now, I put out a series by Professor V.P. Pandey from Indore. I have the data here. Dr. V.P. Pandey is the head of medicine at Mahatma Gandhi Medical College, Indore. He's not, he's one of the very well-respected doctor. In his series of 210 patients, he found that half of them did not use oxygen. He found that only 80% had diabetes, which means 1 out of 5 were not diabetic, and then 14% did not use steroids. Now that is significant data. And now I have a tweet from Anil Vij, who is the health minister of Haryana. Yesterday, he tweeted saying that out of 413 black fungus patients in Haryana, 79, that's 1 in 6, were not diabetic. And 1 in 4 had not taken steroids. So we are on to something here. This is not a steroid diabetes disease. If it is only occurring in one country, it has to be an act of commission, not an act of omission. In MD General Medicine, if you say you have bronchial breathing and if your examiner fails to hear it, you're failed. It's an act of commission. You can't take it back. Once you commit on bronchial breathing, you're failed if it's not there. Same way, we are committing on some intervention for our patients which are not there in other parts of the world. And what are these interventions? The classic thing that comes to mind is especially in rural India, people just, they don't understand vaccination. They're anti-vaccine. They have poor access to medical care, but they all do steam inhalation. Now, steam inhalation, many people look at WhatsApp and they just burn their insides off. And there is substantial concern among pulmonologists that they're going to literally burn off their mucous membrane from in the insides. So excessive steam is what comes to mind. What's interesting also was the presence of trace elements like zinc and iron. Fungi are hungry for these. And our body and all vertebrate cells, they prevent fungal infections by holding back or hiding these trace elements, particularly zinc, from fungi. And that's an established fact. These are papers from 1996 that have shown this. So while we can't say that zinc is actually causing it, we may be giving an environment that is conducive for fungal growth. What we need to do is to look at all the cases of mucormycosis, compare them with controls which are exactly matched, maybe 3 or 4 times the number of controls, and find out what exactly these people were doing more than other people. So we may be surprised with the conclusion. So unless we do such a study, or unless such a study is done, it will be futile to keep blaming steroids and diabetes. That's the point. Thank you.
Okay, Dr. Rajiv, we are running short of time. Dr. Noy, people are worried and over worried about post-COVID syndrome. Can you briefly mention about post-COVID syndrome?
Yeah, so post-COVID syndrome, I think now has to be divided into the acute COVID phase, which is about 4 weeks of the illness, and ongoing symptomatic COVID, which actually occurs between 4 to 12 weeks, and the classical post-COVID or the long haul COVID syndrome that is used is any symptom that developed during the COVID or after the COVID period or acute COVID period, and which continue for more than 12 weeks. And which cannot be explained by any other alternative diagnosis. And that is what is the long COVID syndrome. It can affect any organ. So a lot of lingering symptoms have been mentioned. There has been mentioned about 205 symptoms affecting about 10 systems altogether. The most common ones that we see in the practice definitely are the post-COVID fatigue that is there, patient having the dyspnea on exertion, dry cough, joint pains, chest pains, and headaches, and the classical brain fog, which was actually popularized by Smith after his episode, and inability to concentrate and impaired memory, loss of taste and smell continuing for a long period of time. Significant number of people tell about insomnia and sleep issues and diarrhea. So these are the things that we commonly see. So, but having a lot of these symptoms, I think we have to pick certain red flag symptoms, which include a dyspnea, a palpitation or a chest pain, any focal neurological deficits after that. If the patient comes with an unilateral pedal edema, all those things should be picked up as red flag symptoms. Whether we need a post-COVID clinic, I don't think it is really required, because I think it is the number of post-COVID cases are going to increase, and one single clinic is not going to actually maintain the thing. I think everybody should be actually taking this and actually treating in a particular order. Over to you, sir.
Okay. Dr. Edison, should patient recover from COVID-19 be on anticoagulants or antiplatelet drugs? If so, what would be the duration?
I actually partly answered that question before. No, I told you, because the guidelines are not very clear. In fact, when I went into the different guidelines of the different states, what I realized that the West Bengal guidelines were quite good. They very clearly mentioned that a patient who has recovered from COVID, suppose he has got the risk factors for thrombosis, that is other risk factors like diabetes, hypertension, dyslipidemia, past history of stroke or coronary artery disease. In addition to the normal anticoagulants, he should be put on one of the newer oral anticoagulants, NOACs. That is what they mentioned was suggested was either a direct thrombin inhibitor or apixaban, which is a direct thrombin inhibitor, or dabigatran. That's dabigatran is a direct thrombin inhibitor, or a factor 10A inhibitor like apixaban. And they also actually suggested apixaban as a first choice because it doesn't need a dose adjustment in renal failure. In fact, nowadays when I discharge patients who have risk factors for one of the conditions which I mentioned before, and who has got a high D-dimer at the time of discharge, CRP may have come down to normal, I usually give them apixaban and tell them to follow up. For other patients who don't have a risk factor for thrombosis, ecosprin is given usually for 1 month. In fact, that is also something which some of the Western guidelines mention, and I don't think our Kerala government guidelines mention that. So I would say decide whether your patient has got a risk factor for thrombosis, other risk factors. If he has got a risk factor for thrombosis, it would be better to put him on one of the NOACs, either apixaban or rivaroxaban, or personally I would prefer apixaban because it doesn't need any dose adjustments for renal failure. For other patients, you can give ecosprin at least for 1 month, and it's quite cheap also.
Thank you. Dr. Rajesh, Clinicians are referring patients for oxygen therapy and for ventilation facilities. Can you briefly mention about oxygen therapy and the principles and practice of ventilation?
Okay, sir. Oxygen is a precious drug, sir, especially in this COVID crisis where there is a lot of oxygen shortage. So it has to be used very judiciously. First of all, we should have an oxygen target for a particular patient, depending upon what his baseline status prior to the COVID disease was. In a person who doesn't have any previous comorbid disease, any target of around 92 to 94% of oxygen saturation is pretty much adequate, provided he is not very tachypneic or in respiratory distress. The first choice would be a nasal cannula, something that we call a nasal prongs, and at a low flow rates. Now, any oxygen flow rate that requires that at administration rate more than 5 to 6 liters per minute, then the nasal prongs is going to be a less effective modality. Then you go ahead with the next option, that is an oxygen, simple oxygen mask, where you can give up to 5 to 10 liters of oxygen. Beyond that, you go to the non-rebreathing oxygen mask or the high-flow nasal cannula. The high-flow nasal cannula is an excellent device because it gives you very precise FiO2. It gives you humidified air at body temperature, and it can give you very high FiO2s. Very comfortable for the patient. The patient can simultaneously talk, have food, everything. The only problem with high-flow nasal cannula is that it consumes a lot of oxygen. But high-flow nasal cannula has really revolutionized the management of oxygen therapy in COVID patients. Beyond that, sometimes you might have to go ahead with a non-invasive ventilatory support, especially in patients with some degree of myocardial dysfunction, because the positive pressure that is rendered is helpful for the myocardial contractility and improving the cardiac output. Now, beyond that, someone who is failing on non-invasive ventilator or high-flow nasal cannula, you make a decision for invasive mechanical ventilation. But in between all these things, one thing that really works is awake proning by a motivated patient. So that will be the real baseline principles of oxygen therapy and ventilator therapy in COVID patients.
Thank you, Dr. Rajesh. The discussion on COVID-19 is not complete without vaccination. We'll have a short discussion on that. Dr. Rajeev, the benefit of one vaccine over the other is always discussed. Example, Covaxin, Covishield, Sputnik vaccine, Pfizer vaccine, etc. And the second question is clotting a risk factor to be worried about during vaccination? Please.
I'll take the second question first. About the risk of clots and vaccines. They are more seen in these vaccines that do contain adenovirus vectors, live viruses, because the Covishield and the Sputnik and the J&J vaccine contain these viruses. These clots are described in the J&J and the AstraZeneca vaccine. But clots are like plane crashes. We hear about plane crashes, but we know flying is very safe. But some people are so afraid of flying because they've read about plane crashes. The point here is that the chance of the plane crashing is so small, your chance of dying is much more if you travel in a car, but people don't realize that. Same way, the risk of having a serious clot, I'm talking about unusual clots in unusual locations that have a mortality of 30% even with treatment. Those occur 1 in about 100,000 cases, or maybe slightly less than that, because as more cases are getting reported, the frequency is slightly increasing. They used to be 1 in 1 million, they came down to 1 in 250,000, now it's a little under 100,000. But I always put this in context. The risk of death that every woman in India takes today is 1 in 1,000 when she becomes pregnant. And I think that's a very important, very powerful statistic that will put everything in context. So my point is that they're perfectly safe. We don't have to worry about the chance of clots at all. As far as the choice between different vaccines, there's really no choice between different vaccines. They're all good because ultimately, more than their published efficacy, I'm more interested in the fact that they prevent severe disease. And as all of us know here in this forum, we know that all vaccines are extremely effective at preventing severe disease. But that extremely effective, as Dr. Itichan said, there will be a small percentage that always fail. About 5 to 10% will fail, slip through the net. And that 5 to 10%, when you apply to a very large number, a small percentage of a large number is still a large number. So that is something that we will continue to see. But what we fail to see are the flights that take off and land safely. Same way there are hundreds of thousands of people who have survived without any complication because they've been vaccinated. So I like Dr. Renoy's profound statement saying that I think lack of vaccination is to be listed as a major comorbidity from now on. Thank you.
Okay. Dr. Noy,
Yes, sir.
what's your advice on vaccination in pregnancy and lactation?
Yes, sir. So now I think lactation, the confusion is very clear. The Ministry of Health and Family Welfare has already cleared vaccination in lactation in India. So the pregnancy, definitely it is actually not cleared, and all the drug companies, all the vaccine makers have actually put it as a contraindication. But in abroad, as well as a lot of studies that are actually coming up, and the advices of different bodies, that is the Royal College of Obstetricians and Gynecologists and American College of Obstetricians and Gynecologists, they say that the risk of getting COVID-19 in pregnancy and the resulting morbidity is much more, especially in the second wave, than the theoretical risk from the vaccine. And the Federation of the Obstetricians and Gynecological Society of India has endorsed this particular view, but obviously they can't make a guideline because the government has not allowed it. So when would you actually use this particular vaccine? It is ideally to be used between the first and the third trimester. Why? Because though there are no studies and there are no obvious causes of teratogenicity that is mentioned, it is always better to be safe till the studies come out. So let's not give it during the first trimester. It is very clear that if a patient or if a pregnant woman gets a disease during the third trimester, there's a chance of premature birth. So ideally, we need to actually protect that. So I think the best time to give it is actually between the first and the third trimester. Now, if the government of India is not actually opening it up to all pregnant women, at least a choice should be given, and also some groups among the pregnant women, that is, who has high risk medical conditions, healthcare or social workers, women who are diagnosed with gestational diabetes, who have a BMI more than 40, and elderly pregnant women, that is more than 40 years or so, definitely need to actually get this particular vaccine. So I feel vaccination is important in pregnancy, and that is the way to go. And I am expecting a guideline to come up or clearance to come up from the government of India soon. Over to you, sir.
Dr. Sunny, can you tell us briefly about your conversation with Dr. Piley? It came from our Tuesday night discussions.
Yes.
Can you tell us?
Even 1 month back, Dr. Piley, the president of Federation of Obstetricians and Gynecologists of Kerala and the vice president of FOGI, clearly stated that all pregnant women should take COVID vaccination because he has seen not many complications in pregnancy. And another statement which he has mentioned, even though it is not documented, Covaxin is a better vaccine in pregnancy rather than Covishield. But there is no documentation. And as Dr. Noy rightly pointed out, unless and until the government of India gives clearance for that, the Federation cannot give an opinion with regard to that. But they are of the opinion that all pregnant women should get vaccinated. And Dr. Tijan, a big discussion is going about the interval between vaccination. What's your comment on that?
No, I think the present discussion is morely political. I don't know whether I am supposed to make a comment regarding that. See, it all actually came up with the Lancet study, where they showed that 3 months, that is 12 weeks, actually that is mainly regarding to Covishield vaccine, that is the efficacy was better. So finally, initially the government told, okay, we'll make it 4 to 6 weeks, 6 to 8 weeks. Now they had made 3 months. So at least if you go by scientific evidence, I think for Covishield vaccine, and that's what the government recommends now also. There is nothing wrong in waiting that. We have science. Mind you, we are speaking about hardcore science. Regarding the Covaxin, there is no such data. And regarding the other vaccines which are yet to come in India, like Pfizer and Moderna or Sputnik, I don't think we have data, though Sputnik is trying to come out with a one-shot vaccine. So I will not comment more about this because there are political overtones. All I will comment is about what is actually done in published in the Lancet journal, and it was a good study too.
Okay, Dr. Rajesh, after 2 successful vaccinations, does a booster needed for complete immunity?
Sir, I think that's a controversial question. Personally, I don't know the answer would be the best statement that I can make, because the vaccines have come so recently that we are not very sure how long do they offer protection. We have statements from Pfizer CEOs and Moderna CEOs and all that there is a third dose that's required. I think Britain is even planning to have a third shot of vaccination prior to Christmas and all those things. Now, whether we can really recommend that on a basis, on a regular basis, or what should be the ideal way, I'm not very sure. I probably would get opinions from other panelists, from other panelists also on that.
Dr. Rajiv, please.
Dr. Sunny,
Yeah.
I'll be very reluctant to listen to a CEO of a vaccine company about the need for booster.
Yeah.
All right. So
that is true, Dr. Rajiv. Very apt statement. But Sunny sir, let me just make one statement, which I was actually read in one of the review articles. See, one thing about viruses we should never forget is that a virus mutates only when it circulates. Unlike other organisms, for a virus to mutate, it should circulate. Now, if we have 100% vaccination, let's say the entire population of the globe is vaccinated, there is no more a chance for the virus to mutate, for the virus to circulate. And a virus that doesn't circulate doesn't mutate. I think that's a very important statement, which I read in one of the review journals. That is, mind you, inherent for a virus. And that is, I don't think, nowhere more true than the current SARS virus, the coronavirus.
It's okay. Thank you, all my colleagues. But before winding up the session, may I ask all the panelists to have a short take-home message to the audience. And even now, more than 123 audience are there. So what advice you want to give to the audience? Some short messages. Yes, Dr. Rajiv.
I'll say this, that I think because in modern medicine, we believe in science, and science is different from belief. We all believe in certain things, but science is very different. Science, I believe it's about proving ourselves wrong. That is what makes modern medicine different. We continuously self-evaluate, and if we find that something that we said today was proven wrong 2 weeks later, we have no problem accepting it. I think we should continue to remain humble in that standpoint, and not get married to certain ideas. So that is just what I have to say as a scientist and a man of science. Thank you.
So what's your prediction about the third wave?
About third wave, see, India is such a large country. We can't call it a single wave. There is no doubt that there will be subsequent waves. There's no doubt about that. I mean, you don't have to be a rocket scientist to figure that out. But there will be waves. And I think Kerala and Maharashtra are different from some other areas because we are so well traveled from an international standpoint. So if you really look at the Kerala curve with a microscope, you really can see about 4 or 5 peaks already. We've had about 4 or 5 waves already, if you really look at it. And it's quite different from some others. Say, for Tamil Nadu has a different pattern. They had a very massive wave and it came down, it just crashed down like it came off a cliff. So I think we should not put India into a box. I think we should really keep an open mind, but I think we should communicate this to the community that, people want to believe that it's over, but this pandemic does not get over like a film or a movie. It is going to continue, and we have to fight for a very long time. I think that is the answer to the question about third wave. Thank you.
Okay, Dr. Nai, what's your take-home message? Dr. Nai, you are muted. Dr. Nai, you are muted.
Sir, COVID-19 is just not any other viral illness or a disease which affects only the lungs. It's a systemic thromboinflammatory disease which affects multiple systems and can cause long-lasting effects. We have to understand that. We have to centralize the triage, as I mentioned, but the clinical decisions that we take have to be decentralized so that it is effective for the patient, so that we need to make sure that optimal patient care is delivered without compromising on your safety and your team's safety. That is more important because we are in it for a long time. We are sure, and this has to continue. And I think this is the most important thing that is there. Another thing that I want to mention is every guideline is a living guideline. I think Dr. Rajiv also already said, it is so dynamic. It is like the petrol prices now. It will change on a day-to-day basis. And that is what is actually most difficult to catch up on. always modify the clinical decision based on the categorization, but at the same time, the comorbidities as well as the phase of the illness, then you are unlikely to actually go wrong. Thank you very much for this opportunity, sir. And to the Cochin IMA as well as API and the Department of General Medicine of Amrita for giving me this opportunity. Thank you, sir.
Dr. Rajesh, what's your take-home message?
Step up vaccination, prevent severe disease, be safe. Simple. I think that's it.
Okay, the final take-home message is from Professor Itechen. Yes, Dr. Itechen.
So I think the message which I'm going to give is not nothing new. It is something that has been handed over from generations to all of us from by our own professors. Treat the patient, not the investigation. Every patient is different. Never over-treat, and especially regarding steroids, because I personally have seen in the last 1.5 years a lot of steroid abuse. It has actually produced more problem. And never interpret your investigations in isolation. And since we had some discussion about our pulse oximeter, even that, let me tell you, has got its limitations. So guidelines are okay, but let us not forget that the patient is the one who is in the center. Let us not forget him, and let us treat him and not the investigations. And other thing is regarding the medications, never over-treat, although like Dr. Rajiv told that there will be a lot of pressure on all of us from various parts of society, from our own peers and colleagues to treat. I think we should be bold enough to say that when you don't need a medicine or treat, yeah, you have to tell it doesn't need, you don't have to treat, just wait. And especially so, I say this in light of the cytokine storm. There are some medicine that should not be used before the cytokine storm, and some medicines that should be used only after or just before the cytokine storm. I thank the IMA for giving this opportunity. It was actually a wonderful discussion, interacting with all my fellow panelists and also Sunny sir. Thank you.
Okay, let me thank all the panelists, Dr. Ibrahim Itechen, Dr. Rajiv, Dr. Noy, and Dr. Rajesh. I hope that we have done justice to the expectations of the viewers and listeners. I'm quite sure that the time is very odd to take a much long comment on this. So once again, from the part of API Cochin chapter, we are really thankful to the IMA Cochin for giving us an opportunity to discuss in detail about the COVID and COVID management.